Thank you very much, Surangi, for your kind introduction. And I also want to thank the Dr. Bimsar and the team and the Clinical Society of Navalapitiya Hospital for this invitation. So in this lecture, I will try to speak on managing a subfertile couple, but this is going to be it's a very broad area, and I understand that we are a little bit off behind the time, so I will try to go through a little bit fast and try to finish it within my time limit. So, can I take this? Okay, thank you very much. Thank you. So, first of all, what is subfertility? I think most of us know this. When a couple tries by having regular unprotected sexual intercourse for quite some time, let's say for about 1 year or 2 years, and even after that they don't get pregnant, then of course we say that there is an issue, and then we say that the couple is struggling from subfertility. Why do we give a time period like 1 year and 2 years? That is because most of these couples do get pregnant if they try regularly. The newlywed couples, if they try for about 1 year, 80%, maybe more than 80% would get pregnant. If they try another 1 year, another 50% of the remaining, or a total of 90% would get pregnant. But this is becoming a bigger problem, not only in Sri Lanka, but also worldwide. And now we identify about 15% of all the couples are having this issue. Or in other words, 1 out of every 6 couple has subfertility. So this is a picture just to give you an overview of what's happening when the natural conception occurs. The oocytes that are released from the ovary, they go through the fallopian tubes, and that's where they get fertilized, and they travel through the fallopian tubes, and during that time, these fertilized eggs will divide, and ultimately they turn into a morula and later on into a blastocyst. And it takes about 6-7 days when they reach the inside of the womb and gets implanted. So what are the basic requirements? There should be a sperm, there should be eggs, and there should be a way for them to meet each other. Or in other words, the male should have spermatozoa, the female should have oocytes, oocytes should mature, there should be fallopian tubes, there should be a uterus, and also there should not be significant gynecological issues that could have an impact on their chances. And also many other factors also can have an impact, like endocrine disorders like thyroid issues, diabetes, and so on. So broadly speaking, causes of subfertility, we can say about 25% of those couples, even if we investigate them, we may not find a cause. So those fall into the category of the unexplained subfertility. About 25% of the remaining, 25 to 30, have a male factor issue. About 30-40% would have a female factor issue, and the rest have issues on both parties. So what is the clinician's role? When a couple comes to you, how would you go ahead? First of all, you need to know, you need to do a basic investigation and try to find where the problem is, but you have to manage them as a couple. Sometimes the issue could be only in the man, issue could be only in the female. Whatever it is, the most important role in the clinician is they should try to manage it as a couple without trying to manage it as an individual's problem. And also, you need to have an idea about how much time is left. It could be a young couple, it could be a couple in the middle, like for example 30-40s, or it could be a couple in the old age group. The problem is, especially when it comes to the woman, after 35 years, we know the oocyte reserve declines. So once the oocyte reserve declines, then the things become a bit difficult, right? So one way of identifying the time is the age, and the other one is the oocyte reserve. The male is here, of course, a bit excused because spermatozoa are generally produced even at a later stage of their life. And also then you have to plan what is the best treatment. There are wide variety of treatments you can do. It could be just a simple advice, it could be just ovulation induction, it could be IUI, or the last option, which is IVF. But all these things should be decided at a discussion with the couple. So you have to also take into consideration the affordability as well as the wishes of the couple as well. So I will rush through these. So the male factor, we know the spermatozoa is absolutely required if you're trying to get pregnant. But sometimes the man could have a reduction in the number of the spermatozoa. Sometimes the spermatozoa may not be very motile. Sometimes they have abnormal shapes. So we look into concentration of spermatozoa, progressive motility, and the normal morphology in a seminal fluid analysis report. If it's a mild male factor issue, we can just make a lifestyle modification. Sometimes you can add some supplements, although there is no good evidence for these supplements, or we can also go for intrauterine inseminations. But in cases where the male factor issue is severe, for example, if it's a severe oligozoospermia or azoospermia, then the patient might need IVF. Sometimes, in the case of azoospermia, a surgical sperm retrieval may be required. So these are the reference ranges given by the WHO. It has been changed over the time. It has been changed, I think, several times. The last change was in 2021. And I think most of us are still using the 2010, but it's time for us to change into the 2021 references. But there is no big difference in those two. Female factor, it could be ovarian. Either a reduction or the low number of low egg reserve in the woman, or sometimes the quality could be low, or sometimes the ovulation or egg maturation is not happening properly. So how do we assess the oocyte reserve and the quality? There is no specific test to assess the quality. It is mostly age related. So if the woman is older, we have to assume that the eggs are going to be relatively low in quality. But there are few tests we can do to assess the reserve. Out of these, the best of course is the AMH, it's a blood test. And the other one is the antral follicle count, which can be easily done. I think in our setup, I think there is a separate slide also. In our setup, like in Navalapitiya, most of the patients I don't think would be able to afford AMH. So if you want to have an assessment, you can just do a vaginal scan and have a look at the ovaries, and you can count how many antral follicles are there in each ovary. But this has to be ideally done at the early cycle, usually on day 2 or day 3. And the total antral follicle count will give you an idea. If the total antral follicle count is less than 8 or 10, then the egg reserve is considered a bit low. If it is between 10 to 25, it's average. If it's more than 25, it's high. So in a PCOS woman, they are more likely to have a high antral follicle count. In an older woman, they're more likely to have a lower antral follicle count. So this gives you an idea about the egg reserve and to advise the patient accordingly. So this is a picture of a normal egg reserve ovary and a low egg reserve ovary. You can see in the left side there are multiple antral follicles. Right side there is only 2. And ovulation, commonly encountered. Usually these people do not have regular cycles, and most of these women also have polycystic ovarian syndrome. So how do we identify or confirm whether the woman has ovulated? What is the test? The test is the day 21 progesterone or mid-luteal progesterone. So these tests will retrospectively confirm whether the woman has ovulated in the cycle. If the ovulation is not properly happening, there are multiple medications that we can use, out of which the first line is letrozole. If nothing is working, the last option is going to be gonadotrophins. The next, of course, uterine and tubal factors. Tubal factor is also common. So depending on tubal obstruction, it could be either proximal obstruction, mid-tube, or distal, sometimes this could be corrected. It could be cannulated, tube could be reconstructed, sometimes it could be distally cannulated as well. But if it's not working, then of course IVF is the last option. So what are the tests available to assess the tubes? One is the HSG. It's very patient friendly because it's an outpatient procedure as well as it's a cheap procedure, and it is fairly sensitive compared to the gold standard of laparoscopy, which is about 83%. Laparoscopy is the gold standard for assessing the tubal patency, but it needs anesthesia, it needs your patient to be admitted to the hospital, and it's an invasive procedure. But the advantage, of course, is we can look into the pelvic cavity, and if there is any issue, sometimes we might also be able to treat it at that time. So there are many advantages into laparoscopy, but nowadays we tend to do more and more HSGs and hyposis. But in your scan, if you see adhesions or a cyst or something like that, endometrioma, I would advise you to go for laparoscopy. Fibroids, you don't have to remove every fibroid. The two important factors are the location of the fibroid and the size of the fibroid. Any fibroid that is closer to the cavity, now there is a FIGO classification, I'm sure you all must be aware of. The ones that are closer to the cavity, submucosal fibroids, are the ones that are going to give you trouble. So sometimes the clinician, especially if you're going for IVF, if the patient is going for IVF, it's very important that we make a good environment for the embryo to implant. So in those instances, if you are suspicious, we might even go for a hysteroscopy. And if there are any fibroids or polyps, these will be removed. Otherwise, the distant fibroids are usually less troublesome, and most of the time we leave them out. Endometriosis, I'm no expert to talk on endometriosis in front of Dr. Dhammika Silva, but anyway, endometriosis is a significant problem. Depending on the severity, now there are guidelines on management of endometriosis when it comes to fertility. Greater the severity, the ARTs, advanced assisted reproductive techniques, become the favored or recommended treatment in those instances. But in mild endometriosis like grade 1, grade 2, we can go ahead and try for some time with either OI or IUIs. So treatment options. Treatment options, as I said, it could be simple, it could be just an advice, sometimes to change a bad lifestyle or behavior like smoking, try to do changes in the diet, exercise to get the weight down, or maybe advise on, sometimes they may be having sex on wrong days, you never know. So a simple advice sometimes could make a change and make the woman pregnant. The next option, of course, is ovulation induction, but this is really necessary for the women who are not ovulating properly. So if you go to another country like UK, they're not going to prescribe the woman ovulation induction if she is ovulating regularly. But in our country, that is because if it doesn't work, they go straight to IVF. But in our country, it's not so easy. So general practice, of course, is to recommend some ovulatory induction agents at the very beginning. Idea is to get a good follicle, sometimes to get more than one mature follicle as well. So if you get more than one mature follicle, the chance of pregnancy would be slightly higher, but at the same time, the risk of multiple pregnancy rises with it. So that's why if you compare the oral agents against the injectables, the gonadotropins give better results, but compared to the oral agents, they also give higher multiple pregnancies. The next step, IUI. IUI again is indicated only for the people who have a trouble. Like for example, it could be in a foreign country, it could be a same-sex couple, like in females. So in those, we use IUI to inseminate the woman with donor sperms. Or the couple, if they're having trouble with sexual intercourse, sometimes we may go ahead with IUI. So in those countries, otherwise in NHS, they usually don't prescribe IUI. But patients, of course, can come private and get it. But in Sri Lanka, this is commonly used. if the ovulation, induction and timed intercourse is not working, the next step we go is IUI. If you compare the success rates of timed intercourse, I would say it's about 12 to 13% per each month. But if you do IUI, it's going to be like 18 to 20%. So each month, the chance of pregnancy is about 18 to 20, provided other factors are favorable. So there is a small video of IUI also. I don't think that it is really needed for you all. The next step is IVF. In simple terms, IVF is making the baby outside the body. In the first slide, I showed you that the egg is released from the ova. It gets fertilized as it goes through the tube, and around 6-7 days, it comes into the uterine cavity. So this part we can do in a lab. That's what happens in IVF. So for that, we need to get the eggs out of the body, sperms out of the body, and then fertilize them in a laboratory and allow the fertilized egg to grow in the laboratory setup for about 5 days and then transfer it back into the womb. So getting sperms is quite easy, getting eggs is complicated. And also, the success of IVF will depend on how many good quality embryos will be there at the end of the cycle. Because these excess number of embryos also can be frozen and could be used later on in case the first transfer is not successful, or if the woman wants to have another baby after the first one, the frozen embryos can be used to try for a pregnancy. So to get multiple embryos, we need to have multiple eggs, but in a normal cycle, usually only one mature egg is seen. So that is not enough for IVF. So therefore, we stimulate the women with injectable gonadotrophins and try to make more and more follicles to go into the mature state. So there are 4 stages, roughly speaking, in IVF. There is a stimulation phase, there is a surgery called OR, or oocyte retrieval, then there is an embryology component, and the last is the embryo transfer. Okay, this is how a stimulated ovary looks like. Now, instead of one follicle that you usually see, 1 or 2 follicles that you usually see on a day 11 or 12 after OI, in IVF, you will see multiple large follicles. So the stimulation takes about 8 to 10 days. You have to get the injectables every day at the same time. And one risk of IVF stimulation is the ovarian hyperstimulation that the clinician has to be very careful of. But nowadays we are not seeing OHSS commonly. It's very, very uncommon because I think we are better prepared and the better medication are there and the follow-up and everything is much better nowadays. So oocyte retrieval. This is a small video. So oocyte is retrieved vaginally. So for that, and it will be done under ultrasound guidance as well. So a needle, a oocyte retrieval needle, will be passed through the vagina into the follicle, and the follicular fluid will be drained out. And this drained follicular fluid will be handed to the laboratory, to the embryologist, and they will look under the microscope and tell us whether there is a oocyte retrieved. So likewise, all those follicles are retrieved, and usually, if you have a good response, at the end of the procedure, we may have about 15-20 oocytes. And then the next part is the embryology part, where the fertilization occurs. There are many ways of fertilizing. It could be conventional IVF, which is just mixing the sperms and eggs together. This is somewhat similar to what happens naturally. Or we can catch a spermatozoa and inject it into the oocyte. So it's called ICSI. This is a small video. I think I have enough time. First of all, you have to immobilize sperm. So sperms are always moving. That's why we hit on the spermatozoa's tail, and then it gets immobilized and it's taken into the needle. And then we have to go to where the egg is. attach the oocyte with a pipette. And then the needle is inserted into the oocyte. Once the needle is inside, the sperm is released inside the oocyte. So the advantage of doing ICSI is the number of fertilized eggs would be high compared to a conventional IVF. But of course, if the spermatozoa quality and number is very good, conventional IVF is good enough. If the sperm number is low, if the quality is low, we go towards ICSI more. But otherwise, the conventional method is fairly all right. Okay, so we have to grow the embryo for about 5 days. This is what happens on each day. On the second day, you can see 2 cells. Then thereon it turns into 6 or 8 cells. 4th day, it's a morula. 5th day, it's a blastocyst. And the blastocyst is what we want to see. And this is the embryo we want to transfer back into the womb. Again, the embryo transfer is similar to IUI, but here, of course, we are using a very soft and flexible catheter. And this again will be done under ultrasound guidance. You can see in the womb, the middle area is the endometrium. You can see about 1 to 1.5 centimeters from the fundus of the cavity. The endometrium is thickest, and that's where we want to release the embryo. Generally, the embryo transfers, you can do the embryo transfer in 2 ways. One is a fresh transfer, the other one is the frozen transfer. Fresh transfer is when the embryo is transferred in the same cycle, just after stimulation, or 5 days after stimulation. So there is no freezing involved in the fresh transfer cycle. In the frozen transfer, it's a frozen embryo that is thawed and transferred into the womb. Nowadays, we tend to do more frozen embryo transfers. That is because the success rates it looks like the success is better with the frozen embryo transfers. Probably because in the fresh transfer, it's right after stimulation. We have injected loads of gonadotrophins. The estrogen levels are much higher, and that could also damage the receptivity of the endometrium. So you can see the white dot there, that is the place where we think the embryos are. Embryos cannot be seen, so it is in a small volume of fluid. The small volume of fluid inside the womb is what you can see as the white spot. So do everybody need IVF? No. If you take 100 subfertile couples, about 90% would get pregnant with simple methods. It could be advice, OI, timed intercourse, or IUI. Only about 10% may not get pregnant after all those. So those are the ones that are candidates for IVF. And so the indications for IVF, the couples who have tried previous treatment options, the ones that are having declining oocyte reserve, people who have bilateral tubal blocks, the ones that are having severe male factor infertility, the candidates for donor eggs and embryos, ones who want to try fertility preservation or surrogacy. Success of IVF will depend on 3 factors. One is the quality of the embryos and the number of embryos, the receptivity of the womb, as well as the surrounding environment, or other factors like diabetes, chronic medical conditions, or endocrine pathologies, and so on. The quality of the embryo will depend on the quality of the oocytes and the quality of the spermatozoa, as well as the fertilizing technique, the embryology team, and the laboratory as well. There's one interesting topic called fertility preservation, which is becoming popular nowadays. This is very popular in Western world because most of the women, they tend to delay their pregnancies due to various reasons. Some of them are single, some of them are married. So those patients come to the fertility clinics and they get, if it's a single patient, they would freeze their eggs. If it's a married person, they would freeze the embryos. The advantage is, let's say for example, the woman is 30 now and she has frozen her eggs and she wants to try for a pregnancy at 40 years. Still she is using eggs that are frozen at the age of 30. If she tried IVF at 40, the success rates would be much lower. So she has preserved the fertility. Likewise, the embryos can be frozen and the sperms also can be frozen. So it could be due to social reason and sometimes for medical reasons as well. So people who are undergoing like cancer treatment, chemotherapy, radiotherapy, they tend to preserve the eggs and the sperms before going through that procedure because it could have a significant impact on the gametes. There is also a donor IVF program. So some of the candidates may not have, for example, men may not have sperms. Some of the women may be menopausal even, they don't have oocytes. So in those instances, they go for donor eggs or donor sperms. Or they also can go for donor embryos as well. So the donor program is quite strong here in Sri Lanka because we have donors in our country, but in other countries like Western world it's very difficult to find donors. Surgical sperm retrieval, this is for the patients, the men who have azoospermia. If the testicles are normal in size, if the testosterone is high, then of course there is a good chance that we may be able to find spermatozoa from the testis itself. So it's a small surgery that is performed to either retrieve sperms from the testis itself or from the ductus, right? Usually the sperms that are retrieved by this way are not good enough or they're not enough in number for IUI. So if somebody is going to go for a sperm retrieval, they should be prepared to go for IVF. So the sperms will be retrieved and then they can be kept frozen. And then if there are good number of sperms with fairly good quality, we can stimulate the woman, retrieve the eggs and use the frozen sperms to inject into the oocytes. Surrogacy, there is no law for IVF in Sri Lanka, still. So there is no law for surrogacy as well. So the clinician or whoever who does surrogacy have to be very responsible. And surrogacy is being practiced in Sri Lanka as well. The important thing is, if something happens to the surrogate, who's going to take the responsibility? That is the question to answer. And sometimes the problems could come if the baby, if the real biological parents don't turn up, what would happen to the child? Those are the issues that involve surrogacy, so it has to be carefully done. I think we are going to form a guideline on IVF with the support of the Ministry of Health, which is, I think, already out, but it's not going to be an act. In that, of course, we talk a little bit about surrogacy, and surrogacy is only indicated for medical reasons. It's not for social reasons in Sri Lanka. So medically, if the woman is not suitable to carry a pregnancy due to cardiac condition or due to insuitability of the womb itself, then they can think of surrogacy. But if it is just for social reasons, just because the woman doesn't want to carry, then according to that guideline, it is not allowed. I think that's all. And thank you very much for listening to this presentation. Thanks.